Good afternoon. I'm pleased to be able to join you today to talk about alternative payment models. And we're talking about a typology, which I call population, episode, and provider-based models. I'd like to start off by saying thanks to Linda Resnick, Mary Slavin, but especially to Maggie Witten and to Dari Essenoff for their patience with me and getting this recorded and getting prepared for today's meeting. Thank you very much to all four of you. All right, also want to extend greetings from my home base at MedStar's National Rehabilitation Hospital in Washington, D.C., and also from the Department of Rehab Medicine at Georgetown University School of Medicine, also in Washington. You know, there's been a proliferation of new payment models, or what's called alternative payment models. And if you're confused by what's out there, it's been interesting. I read one place where someone said that CMS has tried out 54 different payment models over its 10-year history. That's the Center for Medicare and Medicaid Innovation. It can be very bewildering even to the most sophisticated health policy analyst. And my goal today really is to see if I can simplify what's out there and see if we can't cut through the clutter in one way or another. Also, I think our discussion and the discussion that follows in our panel discussion really needs a heuristic way in which to categorize these models and their evolution. And despite all these efforts, unfortunately, these new payment models have produced mixed, if not disappointing, results in terms of outcomes and cost. And that will also be explored during our live panel discussion meeting toward the end of this session. All right, so what I want to do is characterize Medicare's journey to value-based healthcare and talk a little bit about how healthcare markets compete today and really ask the question, what is value in healthcare? And that will help frame the discussion that follows. I'm going to summarize two main approaches to this question of how do we get to value-based healthcare. One is the fee-for-service value-based payment systems, and the other is development of alternative payment models. And also we'll try to summarize some of the most salient research findings to date. One time I was interviewing a physician for a research project and on payment reform, and he said, "Tell me how you're going to pay me, and I will tell you how I'm going to practice." And I think that pretty well sums it up. Payment does drive practice, and the shape of payment is really important to understand. If we look at things carefully, what we do today is that we pretty much compete on risk and prestige competition. Health plans in particular tend to compete on risk because they do not want to over-enroll high-risk subscribers. In other words, they want to avert adverse risk selection. And health systems like to compete on prestige and brand. We're talking about competing on who is number one in U.S. News and World Report, who's got the greatest amenities, who has got the most NIH grants, publishes the most, and all of these things are highly touted through a hospital and health system PR offices. So the health system really does compete on risk and prestige, not on price and quality. And the whole idea is to move the health system more and more to price and quality competition. All right, so what is value in healthcare? Well, it's very simple. Value is health outcomes achieved per dollar spent. In other words, we have a numerator and a denominator. The numerator is health outcomes achieved. The numerator is divided by the cost of delivering those outcomes. So basically, when you look at reforms, you'll see reforms aimed at both the numerator and at the denominator, trying to enhance quality and outcomes, but also trying to reduce the cost of delivering those outcomes. So basically we see as a two-track approach to healthcare reform and payment reform. One is what I call the quality metric track, and that focuses on outcomes. And then on the denominator side, we're focusing on payment reforms, all right, trying to reduce cost. Over the years, we've had quite a few pieces of legislation that have passed that have all contributed. And if you look at all this legislation, they all converge on value-based payment and alternative payment systems of one kind or another. I'm not going to go through all these different pieces of legislation, but I think that many of you are already familiar with them. I'd now like to introduce a chart that I'm going to reintroduce multiple times, because this really helps to frame our discussion this afternoon and what follows. It's often said that the arc of history bends towards justice, or they say the arc of history is long but bends toward justice. Well, I like to say that the arc of payment reform and Medicare basically has been arching from fee-for-service to alternative payment models of one kind or another. And what you see are three stacks here. We have the traditional fee-for-service stack, where hospitals, post-acute care providers, and individual practitioners are paid on a fee-for-service basis. And what we've seen introduced over the last several or more years is value-based payment. In other words, these different systems still continue to be paid fee-for-service, but there usually is a reward or some penalty based on the extent to which they achieve certain quality parameters. Then at the far right, we have the alternative payment models, or the advanced payment models, which really tries to get away from fee-for-service altogether. There are really two genres. There's the bundled payment, which is based on episodes, and the accountable care organizations, which is based on population. And I'll keep coming back to this chart from time to time, because it kind of provides a roadmap for our discussion as we move along. Okay, what I do here is really look at the last two columns, if you will. That is provider-based systems, episode-based systems, and population-based systems. All right, and then in the provider side, we have hospital-based, value-based payment. We also do the same thing for SNFs and home health. We do not have corresponding payment systems for IRFs or LTACs at this point in time. And for individual clinicians, we have FACRM Mips, which I'll introduce later on. The episode-based systems are bundled payment for care improvement, and also the comprehensive joint replacement bundle payment. Then we have a number of population-based efforts. They include all the various ACOs. In a sense, Medicare Advantage, which is not part of our discussion here, is also population-based and is capitated. This is kind of the typology that I see. And I'm going to actually skip over the next slide in the interest of time and move directly to the next aspect of our discussion. Here again is our chart. And of course, here we see the provider-based, value-based systems. And here we see the alternative payment systems. And we'll take a deeper dive in each of these, but still treat each of these superficially. So let's take a look at hospitals, first of all. So hospitals, acute care hospitals, have a value-based payment component to their payment system. All right, basically it's funded with a 2% withhold from the DRG payment, and hospitals can earn back a portion of the 2% reduction based on the hospital's what's called total performance score, its improvement or its achievement scores. The way these scores are put together is to look at clinical outcomes, patient and community engagement, patient safety, look at efficiency and cost reduction. Each of these are weighted similarly. They're put into a composite score. And then what CMS does also looks to see whether or not how the hospital, what it achieved relative to its peers, but also relative to itself in terms of its improvement from one year to the next. And that's what informs the amount of payment that the hospital will get. I've greatly oversimplified things here because you can do the whole lecture just on hospital value-based payment, if not a couple of lectures. Then we also, in skilled nursing, we have something similar. It doesn't have as many quality metrics. It's really focused. Its value-based payment is really focused on the 30-day all-cause readmission rate, okay, which is risk standardized, and it really focuses on unplanned readmission. And then what happens is that you look at that readmission rate and you has two components to it, as we do with hospitals. There's how much improvement there was over the previous year, and what was the SNF readmission rate relative to its peers. And that's what begins to shape the payment. All right, and so what CMS does, and like the hospitals, withholds 2% of the SNF payment. Okay, it's called a withhold, and redistributes 60% of the withhold to SNFs as incentive payments. And however, with the public health emergency, i.e. the pandemic, CMS has suspended much of this for now anyway. And then, I want to skip over the QRP program in the interest of time. Now let's take a look at home health. Home health works a little bit differently, but has many of the same parameters. Okay, basically what we've done in home health value-based payment has really been restricted to 9 states, which were kind of considered to be pilot states. And you can see them as they're distributed geographically in the map in front of you. And in this year, in calendar year 2022, this model has been expanded nationwide. During the more limited or initial home health value-based payment system, basically instead of a 2% withhold and then clawing some of that back through improved quality, instead there's a payment adjustment that can be up or down as much as 7% in 2021. So in other words, a home health agency could gain or lose 7% above or below its baseline payment. It's been interesting to see what the results of this initial home health value-based payment system looked like compared to those that were not among the pilot states, and that is to say the other would be the other whatever number of states. Generally, we find that total performance scores were 7% higher among home health agencies in the initial cohort than in the non-home health home health value-based payment states. Decreases also there were decreases in unplanned hospitalizations and SNF use, but it was offset by a 2.5% increase in outpatient visits. It did result in almost $1 billion in reduced Medicare spending, but that was over a 4-year period of time. And some of that analysis, of course, is complicated by the pandemic. Let's move on a little bit more here to look at a little some other features of the home health value-based payment system. Here for the nationwide effort, not the pilot effort that's now underway, instead of plus or minus 7%, it's plus or minus 5%. And it's the adjustment in part is based on various quality parameters, and you can see them listed in the brackets there: quality of care, communication, patient safety, patient and family engagement, patient function, which all gets amalgamated into a total performance score, which is then factored into how much of that 5% bonus they can get or how much they would lose. So that's basically the way the home health value-based payment system works. So let's look at our big chart again to see where we are at for a moment. We looked at hospitals. We looked at what post-acute care facilities, namely the SNFs and home health agencies. And now we're going to be looking at Mips, the merit-based incentive payment system that was authorized under MACRA, passed in 2015. This is all for all the various clinicians, particularly those not associated with large systems. And however, these individuals can participate either as individuals or as part of a group or a virtual group. Now, I must tell you too, let me just go back one slide for a moment. Yes, if a set of providers wants to move directly from fee-for-service all the way to APM, they can bypass a lot of the reporting requirements that you have here. We're not taking a very deep dive into the Mips quality indicators, but there are numerous ones. My big problem with Mips, and I've not really evaluated here, but it's extraordinarily complicated set of indicators with a lot of voluntary stuff, a lot of options and choices that individual providers can choose from. My concern, however, is that a lot of that makes comparisons very difficult. We'll probably discuss that in our panel discussion later this afternoon. There's also a scoring under Mips, and basically it's about 30% is based on quality, 30% is based on cost or reduction in cost, also 25% promoting interoperability, and 15% for improvement activities. And in the case of Mips, the amount you can lose or gain is dramatically more than what you see in the other systems. Instead of plus or minus 3 or 5 or plus 7, it goes all the way up to plus or minus 9. So over the period from 2019 to 2022, what we've seen is that this has been titrated upward, so to speak, in other words, the penalties for bad performance have gotten bigger and the rewards for good performance have gotten greater over time. So now let's take a quick look at the big chart again and where we are. We've pretty much addressed everything that's in this particular column. In the center column here, that's the value-based payment system. All right, where there's basically an add-on payment or a loss of payment based on how providers perform on various quality indicators or other performance parameters. Now we're moving all over to the alternative payment models, which are very different. All right, and so there have been basically two kinds. It's the bundled payment and the accountable care organization, one based on episodes and the other based on populations. All right, let's start with bundled payment. This is a very large and complex topic all by itself. We have the initial bundled payment program called BPCI. I call it BPCI Original. It was in effect from 2013 to 2018. You had many different diagnostic groups that you could bundle into a single payment. I just want to explain further here before I go any further. In bundled payments, we have a whole group of providers coming together to manage an episode of care, and typically for a 90-day episode, which I will explore a little bit more later on. Now we have bundled payment, BPCI, if you will, advanced, which went into effect in 2018 and will run for 5 years. It focuses on a more limited set of diagnosis and also tries to build on the lessons learned in the original BPCI program. Now there's another bundle payment program. It's called the Comprehensive Care for Joint Replacement. Okay, that is, and the hip and knee replacements are the two most common surgical reasons, surgical admissions, and also the most common set of conditions seen in post-acute care. And so there's been a separate program for that, which I'll discuss in just a little bit more downstream here. All right, so let's talk about bundle payment. Well, generally, bundle payment must include both acute and post-acute care. To the 90-day episodes, starting with the admission to acute care. All right, a fixed 90-day price, which is the benchmark price, and then a target price, which is 3% discount for each clinical episode. If you're below the target price, you share in the savings, but you must meet certain quality indicators along the way. All right, here, let's take a look here. Now we're going to go over to ACOs. All right, and we'll just say just a few things here. ACOs is really when you have a group of providers coming together to manage a population, usually be physician-led, hospital-led, or health systems-led. All right, and the basic math behind the ACO model is that Medicare sets a benchmark for the total cost of care per beneficiary. And if total cost is below the benchmark, ACO shares in the savings of ACO. It also meets quality of care benchmarks. And if the total cost of care exceeds the benchmark, ACO pays Medicare for a portion of the total above the benchmark. All right, so let's just move on from there. I'm going to say there's both a one-sided risk and two-sided risk. In the interest of time, I'm not going to get into that at the moment. But basically, if you're willing to take a downside risk as well as upside risk, generally you're given more flexibility in how you manage the care that you provide. There are very many different kinds of Medicare ACOs. There's a long history of them, and they're for you to review here. But generally speaking, right now we have 483 Medicare ACOs. There has been a decline in them. Almost 60% are taking some downside risk, and there are about 11 million Medicare beneficiaries in ACOs and approximately 33 million across all payers at this point in time. Generally speaking, there's a federal grand bargain here. The more you're willing to move from fee-for-service to alternative payments such as bundle payment or ACOs, the more flexibility that you have to manage the resources, the inputs in achieving a certain outcome. Just a few things about some of the main findings to date. CMI has launched more than 50 new bundle payment models. Only 6 have generated statistically significant savings. And really to date, only ACOs have shown materially improved outcomes and savings, and yet the amount of savings have been pretty modest. So those are some of the things that we'd like to discuss in the panel discussion that follows. So as Michael Porter once said, innovation and value are less and less about the science and more about how we deliver care. And I think it's very, very true. With that, I just want to say thank you, and please save your questions for our discussion, which will come toward the end later on this afternoon. With that, I want to say thanks to all of you for participating today, and very much enjoyed being a part of this discussion. Thank you.